somebody's using ixazomib Lendex for the first time, I would say the things to think about are the dosing of ixazomib is 4 milligrams once weekly, 3 weeks on, 1 week off, so day 1, 8, and 15. It is important to adjust the dose of ixazomib if somebody has impaired renal function. We did the pharmacokinetics study at Mount Sinai, which showed that patients who have impaired renal function with clearance less than 30 do accumulate the drug at higher levels. So for those patients, Nilaro or ixazomib should be reduced to 3 milligrams. As with all proteasome inhibitors, Zoster prophylaxis is required. We have seen recent data that the new Shingrix vaccine, which is killed, has been shown to be safe in myeloma patients. In terms of its benefits, we don't know yet. We don't have long-term data. But I think in this patient population, if you're going to be using a PI, regardless of vaccination status, patients should still be getting shingles prophylaxis. And of course, because of the use of lenalidomide with dexamethasone, the thrombotic prophylaxis is equally important, typically aspirin daily. If somebody has a history of thrombotic events or is high risk because of immobilization, surgery, airline flights, therapeutic anticoagulation with enoxaparin or Xarelto, the like, would be advised. The one thing that I think I would do in personal practice that is not technically on label from the study is if you ask patients what's their least favorite drug, it's dexamethasone. And so we do this IRD regimen per protocol, which is 40 milligrams a week of dex. But if you've debulked the patient and you really now are just trying to maintain their remission, do you really need to get your patient not sleeping every day, gaining weight, being irritable? I think it's very reasonable to taper the dex off and just maintain patients on ixazomib and len to allow them a better quality of life and the side effects of steroids. So in summary, we saw here a standard risk myeloma patient who got induction, transplant, maintenance, and then relapsed off maintenance about a year off after lenalidomide and got ixazomib Lendex for relapsed myeloma. He had a biochemical relapse. So I think this case highlights a lot of the considerations. We discussed the importance of looking at patient factors, disease factors, and treatment factors. It's nice to have so many choices in myeloma and treating relapsed myeloma. And so when we consider those factors, there will never be one right regimen for all patients. And in a patient who's looking for a completely oral regimen that's efficacious, that can be given because of the convenience till progression, IRD is a great option.